So I think one of the most useful things we can do is talk about very briefly how to avoid becoming deformity creators, but most certainly in this course to talk about how to fix it when it's there. I think high pelvic incidence patients always pose unique challenges, whether you're correcting a large deformity or simply doing a single level spondylolisthesis, which seems to be quite common in a high PI population. Because of the weight-bearing axis and because the patients need a large amount of physiologic lordosis, if you lock them in flat, they fail dramatically and fail quickly. This is a 51-year-old who was sent to my clinic and had a single level to start, as you can see by this x-ray at an outside hospital, and ended up coming to my clinic looking like this. And this all happened to her in less than 2 years. And at 51 years old, this is a fairly large disaster. And now we're sort of looking at how are we going to correct this and get her in the appropriate alignment. So again, it's a high cascade volume. When you're a high pelvic incidence patient, you have to be very careful to get the alignment correct, even in a single level TLIF. One thing that I think we have not talked a lot about today and that is very relevant in the spine deformity population is the concomitant incidence of hip pathology. And particularly for me, when I see a patient standing with flexed hips, which is very common in all of these deformity patients, I always have to ask myself if they actually have a hip flexion contracture, which can certainly be present. So I always remind myself to evaluate for that in my clinic, simply by having the patient supine and seeing if they can fully extend their hips. And that's important because if someone has a hip flexion contracture and you attempt to correct their spine and ignore that, that can be very difficult to obtain the desired alignment to stand upright. And also important in patients who, especially high pelvic incidence patients who have had prior total hip arthroplasties, if you're correcting a fairly substantial amount of sagittal deformity for them, there is a very real risk of dislocating the cup in the future, certainly not right in the immediate post-op period, although we had someone that had done that in the first 4 weeks after surgery, because you're changing the weight-bearing axis across the arthroplasty. And basically the cup is not in the anteversion zone that the hip surgeon initially thought it would be because you're changing the weight-bearing axis. So that's just something to be aware of. And I think this algorithm on the screen nicely describes what would be a safe approach to doing this. And certainly we always talk with our hip colleagues if we have a patient that we're concerned about ahead of time. This is something that everyone on this conference is very familiar with, but one thing that I want to highlight and that others have also said is that the workhorse of my daily practice is the Schwab grade 2 osteotomies. And certainly we do 3-column osteotomies whenever they're needed, but in my practice, I agree with what Dr. Gupta and others have said, which is it's mainly reserved for patients who have fusion mass. And the workhorse posterior column osteotomy is accompanied by interbody fusion really can get you in a mobile disc space, almost everything that you need. So I think that's just something I wanted to emphasize. TLIF gets a bad name, and it breaks my heart when that happens because truly TLIF can be quite a lordosing operation, and this is just utilizing bilateral facetectomies and also bilateral interbody cage placement, but certainly utilizing the lordosis capability. You can see going from 15 degrees lordosis to 42 degrees lordosis with just a 2-level TLIF there. We talked about releasing the ALL, whether inadvertently or advertently, from a posterior approach, and that's obviously a very potent technique, but this is not required to obtain this amount of lordosis in this TLIF. So something that I think is emphasized is that where you put the cage in the disc space in the anterior posterior realm actually can help or hurt your lordosis. So you could put in an 18-degree lordotic cage in a TLIF. If you put it posteriorly in the disc space when you attempt to close that osteotomy, which is in the figure B, that's going to block your reduction and your correction and your ability to obtain the lordosis. So that's just something that I just always mention as part of the sort of the idea of creating more lordosis with less technique. And I think it's really admirable that all of us are constantly learning, and that's important. And we all want to adopt new techniques into our practice. And I think it's really important to talk with senior surgeons who've done all these things and to go visit them, to speak with them about their experiences offline. I think those are all really valuable. Ultimately, for your patient, you have to use the safest technique in your hands. And if you're better at a lateral interbody fusion than you are at a TLIF, that's fine. Whatever you need to do to get the correction, just realize all of us have the opportunity to refine and improve our techniques, but we have to do the safest thing for the patient. I think one thing is that with a very tall cage height, you can also block your ability to obtain lordosis. So that's something also to watch if you're creating iatrogenic deformity by putting in too tall of a cage and not being able to close down posteriorly to obtain lordosis across it. It doesn't matter what the lordosis of the cage is if you block your own correction that way. Dr. Gupta had mentioned in his talk, basically table-based correction with a hinge table. We do utilize the table that he depicted. Also, there are many different options you can use, but I think that really helps in avoiding stress on the implants during deformity correction. So just to go into some specifics here, utilizing a case to illustrate some of these principles, this is a patient with a previous L2 to S1 fusion mass, and she basically is a classic flat back deformity. She is a high PI, she's a normal PI, and so unfortunately from L4 to S1, she's about 20 degrees, and ideally she would be 30, 35 degrees. So you have to ask yourself, well, what am I going to do to get lordosis there? Obviously a 3-column osteotomy with her fusion. So the thing that I like to do in my office is get the most out of the least. And what I mean by that is get the most information that I can out of the imaging that mostly already exists when the patients come to me. So this is a scalp CT scan that gives me a flexible an idea of the flexibility of her deformity straight out. So we can see that that coronal deformity corrects. The sagittal deformity obviously is not going to with the rods, and even if she's arthrosed. So we'll use that. We'll also use opportunistic bone mineral density at our UIV based on the CT scan measures that we have there. And there are variable published thresholds in the literature. I know we've talked about this a little bit, but essentially in my practice, anyone who has Hounsfield units less than 100 is going to get an automatic bone health referral for an anabolic bone density agent prior to deformity correction surgery. Other things that I'll look for in the CT scan, I'll try to suss out the type of instrumentation in there. All of us going all the way back to, I had Steffi plates I removed the other week. So these are, it's very helpful to be able to recognize the instrumentation if the opera ports are not electronic and unable to be easily obtained. And I also will look very closely for fractured screws, because many times pedicle screws will fracture within the pedicle itself, and you can have to use a trephine or various techniques to extract the screw if you really need to obtain rigid fixation at that level. So that's all things that I want to look at on my pre-op CT scan. And I think preoperative optimization as a preventative measure is really important. I mentioned the anabolic bone density agents. There's no magic number for how long to do that ahead of time. I'm sure everyone in the audience has different preferences. In my personal practice, if it is an elective operation, it's a minimum of 3 months on an anabolic agent prior to proceeding with the deformity surgery. We also do a pretty strong nutritional assessment. You can read the lab values on the screen, but we also engage in prehabilitation using therapy for cardiovascular fitness prior to undertaking these large deformity corrections, also utilizing supplements protein-wise before and after surgery, and ensuring the patient is nicotine-free, which is often the biggest challenge of all. So intraoperatively, how are we preventing our deformity risks? Essentially, many of us will use TXA, utilize some device as a cell saver means. And I think it's very important to realize the higher your blood pressure has to be, the more blood you're going to lose, but some patients require that. So patients with cord compression, cord injury, cardiac perfusion deficits, all of those patients are going to have higher blood loss, and you have to recognize that ahead of time. We use IV lidocaine for pain control. It has a secondary benefit of being a neuroprotective, so that's also a benefit for us. And hypothermia is a big enemy for all of us doing deformity, and I'm sure everyone in this room has basically experienced a very hypothermic patient who may have ended up with a wound infection. So that's something that's very important. As far as how to plan surgery, I believe we're going to have another talk about this, so I won't go into too much detail about this, but I just wanted to point out some of the weaknesses that exist in preoperative planning software, because I think it's really great to use, and I use it all the time, but I think it's important to recognize its current limitations. And so it's very careful to review your plan and make sure you've dialed it in physiologically. So this particular plan, in the case that we're talking about, just wanted to draw your attention to, there's a PSO at L5 getting 25 degrees, which is great. But at the TLIF levels, which in this patient are L1-2 and L2-3, because previous fusion mass, basically we're asking for 14 millimeter high cages with 12 degree lordosis. Getting a 14 millimeter high cage in a completely flat disc that has some, osteophytes around the edge of the disc space is very challenging. So setting up a deformity correction plan like this looks great, but you have to be very honest with yourself if you can actually achieve that physiologically in surgery. And you can choose these patient-specific materials such as pre-bent rods, et cetera. And there was a lot of talk today about, rod bending and notching. I think one of the advantages if you're using a pre-bent rod for a 3-column osteotomy is often that rod will have close to a 90-degree bend, and if you're doing that intraoperatively, certainly you can introduce notching and repeated bending to get it right. So that is one advantage of a patient-specific rod. One thing that we had talked briefly about, not briefly, but in detail, about having 4 points of pelvic fixation. In this particular patient, her S1 screws had such large halos that she would have required 10.5 diameter revision screws. So we certainly plan planned not to do that. That is a very difficult and large screw to put in S1, but to put 4 points of pelvic fixation in, certainly, as we do with most patients who have low lumbar PSOs, to make sure we get 4 rods across the lumbosacral junction for stability. And our technique actually is to use 4 sacroiliac or S2AI type trajectory screws. As Dr. Theologis mentioned earlier, you can't technically do S2AI for both screws. One of them ends up a bit lower, but we certainly can get 4 in every patient I've ever had, except for one that had a previous SI joint fusion. I just couldn't get 2 on that side. So our preferred technique, again, using that, and these are just some snapshots from a navigation system intraoperatively, but the way that we reliably get 4 S2AI screws in is that we make the first screw, the collarmost screw, just above the sciatic notch and parallel in the upper left quadrant there. You can see that to the parallel to the sciatic notch, engaging that very strong cortical bone along the sciatic notch. And then we offset that screw somewhat medially, and we plan the more cephalad of the 2 S2AI screws to be in line with usually the S1 pedicle screw, so that accommodates 1 rod. And with the second point of S2AI fixation, we'll have that slightly medial, so a secondary rod can be accommodated. And we usually span that up to a dual-headed screw, depending on what the level of the PSO is, at the level above that, for a 4-rod construct across the 3-column osteotomy site, hooked into 4 points of pelvic fixation for enhanced stability. We had found, and one of the reasons I think that's really important, is we had noticed what we considered a very high rate of failure of pelvic fixation. And pelvic fixation doesn't pull out. It's strong enough and deep enough and wide enough, but the set plug is a mechanism of failure, particularly in open tulip screws. And we noticed that in our own center and published it, and then we thought, well, we should do a multi-center analysis of this. Maybe we're just really bad surgeons. So we engaged 13 academic medical centers across the United States with this, and actually we found the same rate of acute failure within 6 months. And so we looked at factors that could lead to failure. Basically, we found, of course, if you undercorrect the sagittal alignment, that can predispose to pelvic fixation failure. And interbody was very protective at L5S1 for pelvic fixation failure prevention. Dr. Theologis mentioned he always uses 8.580 screws or above, same in the study, that was protective. And using more than 2 points of pelvic fixation if you're going to do significant deformity corrections. We measured T1PA as one of the magnitudes, and also pre-op to post-op lordosis change. And so that is very important to consider, using more than 2 points of pelvic fixation if you're doing large deformity corrections, particularly in PSOs at the lumbosacral junction. And a last thing we found that we hadn't thought as much about was that if you over-angle the S2AI screw, or even the iliac screw and connector head to reach the rod, it has a much less ability to resist the set plug failure by torque popping off the set plug, particularly in the open head screws. And we had published a biomechanical study that if you tighten your set plug when you're doing the counter torque mechanism at the end of your case, if you tighten your set plug sort of reliably over a second or two, rather than twist it off as fast as you can, that it actually retains an increased torque limit to resist the pop off of the set plugs. So basically, optimizing pelvic fixation in your deformity corrections, again, consider when it might be helpful to have more than 2 rods across the lumbosacral junction and hooked to more than 2 points of pelvic fixation. We've already talked in detail about the kickstand rod, and there's a very nice demonstration of that. That's very important, particularly as I am demonstrating here in these pictures. One thing that's crucial, of course, is to lock in the lordosis that you create prior to basically distracting across your kickstand rod, or you'll distract out the lordosis you created. So that's just something to emphasize. And again, this particular patient has 5 points of pelvic fixation without a problem. Certainly plenty of room. So as Dr. Gupta mentioned, this does not displace the need for bone grafting, and we actually will bone graft before we put the rods in, because as he mentioned, you can't reach underneath those rods to do that very well at all. Certainly you can't decorticate very well under those rods. So you absolutely have to have meticulous bone grafting techniques the more rods that you use, because they do take up space. And intraoperatively, assessing your patient alignment is really critical. Oftentimes you've done a 3-column osteotomy plus or minus multiple more, and you're tired and it looks like it probably is good, but taking the time to download the whatever server that you need so that you can measure your angular correction is really important, I think, in obtaining your ideal alignment here. And this particular patient in this x-ray has 6 points of pelvic fixation because we had utilized a kickstand on one and more complexity. So we initially started with this case discussion and with the planning. And I think, obviously a preoperative planning software does not replace intraoperative technique, and the technique that you use needs to be the safest in your own hands. And as Dr. Gupta mentioned previously, utilizing a dual surgeon approach when you're first beginning to do 3-column osteotomies is very helpful. For the first several years after my fellowship, I did that routinely and still will on very complex cases. So I think that's actually a really important key. And many of your partners, or even people that aren't your partners that are in your healthcare system, would probably be very willing to engage with you on this because it improves patient safety. So I think that's really important as well. So thank you very much for the opportunity to give this talk, and I'd be happy to take any questions. I very much appreciate it.
Well, very nicely done. Can I ask, when did you finish your fellowship? I was just curious.
2015.
2015. Well, congratulations, and on your accomplishments. And I also want to call out, it's one of the things that kind of irks me about my chosen field in spine surgery is that we don't have anything close to equilibrium in terms of men and women practitioners, and that's way overdue. So I commend you for leading a charge. And I'll tell you, on a personal level, my wife is a surgeon and a liver transplant surgeon, and I am familiar from some of her stories of some of the difficulties that she encountered on her professional path. So I'll start with that and then open it up to the audience here. Any further questions? Alekos?
Don't come to me.
Okay, Munish.
Kristen, great job on the talk. I have a question for you. So I saw multiple iliac, or there are S2AI screws. Is it those are different than the ones Alekos was demonstrating? Is that correct?
That's correct, yes. So typically one similarity to what Alekos had demonstrated was that he'll do sort of a subcrestal insertion technique for his iliac screws when he's using multiple iliac screws, and we will do that as well. Of course, you don't want the prominence of traditional iliac starting points. The S2AI, I just think it's important. It's really hard if you don't ask someone about the nuances of rod placement. You can end up with a mess at the end of surgery, even if you get the extra points of pellet fixation. And so I think it's important, the tips about sort of where to put them to line up your rods for optimal placement if you need to put multiple rods in. And as I mentioned, with the 4 S2AI screws, leaving the most caudal screws slightly medial has worked very well, just because number one, of the shape of the sacrum itself, but number two, it just allows to line up with the medial rod to a higher lumbar screw.
Well, I think, as I said earlier, maybe it's a postprandial effect. Maybe it is just the length of the program. But I really appreciate you taking the time, and I'm sure we will get an opportunity to meet face-to-face down the line. And please give my regards to Dr. Pauly when you see him.
Thank you, I will.